Hi, my name is Leona Landazuri, and bear with me, this is like the 5th time that I've recorded this. The reason why I chose disparities in healthcare is I find that I have a bit of personal experience in this, being that I do work in a hospital setting, and I do work with and around patients who do not have insurance and do not receive the type of healthcare that I feel they generally need. So before I start, I wanted to show some of the handouts that I was using. I wanted to speak about Wayne Riley and his article that he wrote in 2012, Health Disparities, Gaps in Access, Quality, Affordability of Medical Care. In this article, he really goes in about the racial and social injustice about patients who, are of color and who do not generally receive the medical attention that they need or do not have the insurance coverage in order to receive, the medical care that they require. So, before I go into the research, I wanted to talk about some of the personal experiences that, friends or family or some of the colleagues that I know have had with patients who do not have insurance, when having their own insurance, and with ethics of patient care that they have found. So, first experience I really wanted to talk about was one of my friends who unfortunately does not have her career yet. She does not have a career job. She works in a department store, and unfortunately she does not fall under her mom's insurance anymore, so she has to pay for her own insurance. So generally speaking, lower jobs, department stores, grocery stores, the working, construction, things like that, you don't generally have the best forms of insurance from these jobs that you work at. You generally have to pay monthly bills into them, and then also have to pay into yearly deductibles in order to receive, the health and the medical attention that you need. So this is a circumstance that she goes through. She has to pay into a deductible each time that she needs to, have a yearly checkup. She needs to go into the emergency room or the urgent care for, short illnesses that she has. And be that as it may, she doesn't really get her normal medical care that she should be getting because of this, because she cannot afford it, being that a fourth of her paycheck every month goes into her insurance, and then some with the deductible that she has to pay into. She cannot afford to get the medical attention that she needs, and so she skips it. So she generally goes on with the illnesses and short illnesses that she gets, and she just lives with it, which in turn can be really it can really affect her health with her body, and in future cases as well. Another case that I wanted to speak about was my brother, who recently lost his job and gained another one. So being that, in the United States, in order to live in the United States, you have to have some sort of health care coverage. And Obama, back in 2010, enacted that, and he implemented Obamacare and Medicaid, which is the insurance that we get from the government that is provided to lower income people and to people who do not have jobs, of course. And be that as it may, he had Medicaid for about 4 months, and he did use some of his Medicaid funds. And then when he got his job back, the government billed him for every single Medicaid fund that he used, which in turn he had to pay back about $1,500. And unfortunately, people cannot really afford that when they first get their jobs back, if that even happens. So it's a really concerning for people who need this health insurance but can't afford it, and can they really afford it even though it's free to them? That's another thing that I wanted to go over. Some of the other things that I wanted to go over about ethics is I have a couple of colleagues who gave me instances about their patients. So I have one colleague, she is an RN at San Antonio Regional Hospital, and she told me of a patient that she had once before who was mentally impaired. He had mental retardation, and he didn't really understand what was going on when he went into respiratory failure and he had to be coded. So, being that as it may, he got intubated, and when the pulmonologist went to intubate him, he did not administer any type of paralytic or sedation. And unless you work in the healthcare, you don't know, but when you're intubated, they're sticking a tube down your throat into your lungs in order to give you the right amount of oxygen supply that you need. And you have to be sedated, or you have to have some sort of paralytic in order to relax the muscles in your throat and also relax, your body, because you can go into shock when the tube is inserted into your throat. And what happened with him, being that he was mentally retarded and he could not really fight for himself, the pulmonologist used that as the justification as why he didn't need to administer the sedation. And when I was told this, when my coworker told me this, I felt I had no words. It's just very unethical, and it's what ended up happening was she sent in a report, and the hospital actually had to, pay for what they did to this patient. Another story by another colleague of mine who is also an RN at the same hospital, she told me about a patient who did not have insurance. And what ended up happening was he was an illegal immigrant, and he was from another country. This patient required a hospital stay, and he ranked up a bill about $100,000 at the hospital. And he could not pay, of course, because he had no insurance, and he did not have, obviously, a very high-paying job. So what the hospital ended up discussing was deportation, which in turn was an unsafe discharge, being that he needed rehabilitation services and follow-ups and, medication lists in order to stop his reoccurring illness from happening. So he did not get deported, luckily, but just the thought of the hospital considering deporting him was just very unethical. And the nurse who worked on his case just felt, the lack of justice for this patient. So with those happenings and with those circumstances and those unethical concepts that we experienced at this hospital, we found that this is something that happens throughout the entire United States and sometimes throughout the world. And we just want to say that it's kind of sad, to have to deal with this type of thing. And when this could, easily be fixed. Going on to my research project, I kind of wanted to just give out a little bit of not a lot of my research. I don't want to read everything off, but I just want to give a couple of quotes from some of the books and articles that I found that were really, you know, appealing to me, that kind of fit in with my work really well. So, on one hand, in my essay, I kind of speak about people of color and patients of color who feel discriminated against because of the tone of their skin. And I read a book, it's called Just Medicine, a cure for social injustice. Sorry, a cure for racial inequality in American healthcare. Sorry, by Dana Matthew Bowen. And what I really quoted from this was, physicians strive to limit their exercise of discretion to considering only the facts that are empirically supported and medically relevant. They take into account race or ethnicity in the course of the patient's care only when and to the extent that those factors are relevant to diagnosis and treatment. For example, racial cues can influence medical decisions appropriately where family history, disease etiology, epidemiological patterns, social influences, and anthropologic data are concerned. So what Bowen really was stating in that quote was doctors only use racial cues and anthropologic data when necessary to the diagnosis of the patient. So I can give a little bit of an example of that. Patients who are Black and African American, they can experience an illness called sickle cell anemia, which primarily only affects their anthropologic group. But there's also another time when we also experience like squamous cell carcinoma, which only affects, Caucasians and white people. So we find the cues of the skin tone sometimes in order to diagnose the patient and what is actually going on with them. And, for the most part, we want to believe that this is true, but I have read some experiences online from people of color who really go on about their experience about how this is not true. And I'm sure that, sometimes that can happen and has happened before. Another quote that I went on to read from Wayne Riley in his article, Health Disparities, Gaps in Access, Quality, and Affordability of Medical Care. He states, the consequences of being uninsured are significant and include use of fewer preventative services, poor health outcomes, higher mortality and disability rates, lower annual earnings because of sickness and disease, and the advanced stage of illness, i.e. many are sicker when diagnosed. Thus, the uninsured tend to be disproportionately poor, young, and from racial and or ethnic minority groups. So this kind of ties in with the minorities and the article that I used by Hugh Jusson about, health insurance coverage through the life course and, people who are from low income and ghetto areas. This is all explained in further detail in my essay, and I really go on about minorities and the insurance that they are provided, by their jobs, by their income bracket and where they live. And it just really goes into much more detail. But really in all, I kind of tried to explain towards the end what I felt like would, fix the social injustice and of people of color and the unethical disparities that minorities experience. And I felt that it is important to realize and change the unconscious racism and bias against people of color and those who do not have insurance. And that is what I ended my essay off with, and that's what I felt would fix some of the disparities in healthcare with the focus of insurance with minorities and the ethics of it all. Thank you.